primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Maryal Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
I want you to know that direct primary care is the best way for a family physician to create a relationship. It is the relationships that we have with our patients that gives us joy. That joy in medicine is very important. It keeps us from burnout. It keeps us happy. It keeps us practicing longer. So DPC is the way to do that, to have that relationship, to create that power to the two of you together. I am Dr. Teresa Lovins of Lovin My Health DPC, and this is my DPC story.
Dr. Teresa Lovins, MD, AAFP, is a nationally recognized family physician and current member of the American Academy of Family Physicians Board of Directors. And today is the physician owner of Lovin My Health Direct Primary Care in her hometown of Columbus, Indiana. Dr. Lovins has been a lifelong advocate for patients and family physicians, serving as past president of the Indiana Academy of Family Physicians, trustee for the Indiana State Medical Association, and delegate to the AAFP Congress of Delegates for the past 8 years. She has dedicated her career to advancing family medicine and improving healthcare access, and now she is running for AAFP President-elect, bringing her passion for innovation, leadership, and advocacy to the national stage. We are almost to October, people, and October is the big month where the Congress of Delegates is going to be congregating, doing their thing, and voting the next American Academy of Family Practice president. And I have the fantastic Dr. Teresa Lovins. I even in preparation for this interview, I was like, she already has her entire campaign written out for her with a jingle and everything. And I kept on singing to my kids like, da, 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 I'm loving it. And so I am so excited to have you on the podcast running for the American Academy of Family Practice presidential slot to elevate what you are doing as a physician, to elevate what we are all doing as DPC physicians and what we are doing as family medicine physicians. So welcome, welcome, welcome to the podcast, Dr. Lovins.
Thank you. I appreciate it very much so.
When we think about you being in the place that you are at the spot of running for the national organization of family practice physicians that most of us know about, most of us have at some point in our career been a part of, if not, we're still a part of since medical school. I'm wondering if you can just bring us back to the start of your family medicine journey.
I only ever knew a family doctor growing up. Ironically, this space that I'm in for my DPC practice was his first space in town. So I'm back in my hometown.
Wow.
And so I really got to know what family medicine was all about. And when I went off to college, I really thought I wanted to be a high school science teacher. And some interesting person in the class sitting next to me said, hey, you know all the classes you're taking for that? You could get into medical school. And I went, hadn't thought about it. But then I actually started looking into it a little bit more, got involved with the medical. It actually was an interest group of college students looking at medicine, and started doing some research in the medical school lab, and then decided to go to medical school. It was really interesting in medical school. Every single rotation that I went through, it was like, I want to do this. I want to do this. I want to do this. And I finally realized, that's family medicine. And so from that standpoint, I got involved with the family medicine interest group here in Indiana. I got very active in the Indiana Academy as a student, and then again as a resident, and have been active since that time in organized medicine.
That's great. And I'm wondering, fast forwarding a little bit, because you are running for the president of the AAFP, what do you see right now when it comes to people who are in the shoes that you were once in as a student, as a medical student resident attending, who are actively making waves in the issues with accessibility that we have in primary care.
Yeah, I think that a lot of the interest in students and residents is trying to figure out where they're going to fit into being a part of the family medicine movement. And so it's very important that we make sure that they're aware of how varied the career options are in family medicine, from anything to everything. When I initially started my practice, I worked with a great big group. There were 10 of us in the group, and we did full spectrum family medicine with OB. And I really had never thought about anything else than that. And so making sure that those students and residents know that they have the ability to do what they want to do when they leave residency is very important to me. And I think if we can keep them interested in family medicine, then we're going to keep them as physicians, and we're going to keep them being able to see patients in the communities where they're serving.
And I will say, keeping people interested is like the understatement of the need thing that we need right now at this time in this country's healthcare journey, because we know that the baby boomers are needing primary care. We know that people who are young and are going to be losing access to Medi-Cal, Medicaid benefits, or going to be needing to prove that they're working to access certain benefits. Primary care, where we deal with 80 to 90% of everyday issues for everyday Americans, is so needed, and it is so rewarding of a career. Before we started recording, I mentioned that this has been the most DPC days of DPC days for me, and I will say that in another recording deep dive into my not even 4 o'clock p.m. Pacific time right now. But for you, I'd love if you can tell us about your practice, because I do think that there's going to be people listening who are sort of aware of what DPC is, but they're also people who are saying, but I thought it's concierge medicine, but I thought it's for rich people, but I thought that people who have Medi-Cal or Medicaid can't access it. So tell us a day in the life of Dr. Teresa Lovins at Lovin My Health DPC.
So I come into the office significantly before my first patient is scheduled, just to make sure everything is ready, because I'm a micropractice. I don't even have any staff here. And so I try to make sure everything is ready to go when I get here. Today, I've done a well child visit with vaccinations. I did a physical on a patient who hadn't had one since her child, who's 12 years old, had her last physical done. I have taken care of warts today. I've taken care of some skin cancers. I think, let's see, what else have I done? I mean, it's just been a varied day. I mean, just anything that walks through the door is just something different. This particular practice of mine is now 5 years old. I made the lucky honor of having decided to do this during COVID and got it started. And it's grown just like I've wanted it to, which is kind of slow, which is okay for me. That has allowed me to be active in the AAFP and do the advocacy that they needed, as well as what they needed at the state level. I have a colleague who's here in town. You've interviewed her, Dr. Dornfeld, and she assured me that anything that I needed, we could share. And so we do. We share vaccines, we share equipment, we share supplies. So it makes it very convenient to have somebody kind of right here in town who can be here for me. And then just moving through the practice, it's not concierge. Yes, I have patients who have quite a bit of money, who have good insurance, but they've chosen to come see me because they like the access. They like the ability to just talk to me and spend a little bit longer time with me. Or when they bring in their child with a rash, they want to talk to me about their menopausal symptoms. It just makes it easier. I also have patients in my practice who don't have insurance, who either have a Medishare kind of coverage or actually don't have any coverage at all. And so I work with them to try and help them find medicines and just any way that I can to help them save money. And then there's that whole group of patients that have those high deductible plans. Seems like there's a lot of those in Indiana. There's a lot of employer sponsored insurance that's all self-funded. And so that's how they come up with their pricing. And so the ability to try and help navigate the healthcare system, keep them in my office as long as I can before they have to go and see the specialist or get the diagnostic tests done. It all gets done, and it all gets done by me. And I love it. It's a part of I think just being involved in that part of medicine, that when I was doing corporate medicine, it wasn't things that I was asked to do, but things that I was interested in. And I think there was a time when I had an office manager who was a little scared because it seemed like I was asking the wrong questions to her, and it became a little animosity to it. But I love what I'm doing now. This was probably the best thing for me. Been married for over 35 years, and my husband said I'm a much happier person now. He's not in medicine. He he laughed. He told me he's an accountant, and accountants by nature are risk adverse. And he said, you got to do this because this is just what I had when I grew up here in town with my family doc, and you've got to do that if that's what you want to do. Part of my campaign for the AAFP is looking at joy in medicine. And I think I just got so burned out with corporate medicine and being employed that I was looking for something. And I had heard about the DPC movement before, but it really was just more of a offhand comment out there. And when I started looking at it more, it became so much more intriguing to me. And it came at the right time for me. And I am so ecstatic that I've done it. When patients ask me, well, why isn't this concierge medicine? And I'm like, well, I don't, I deal with insurance to help patients get their prior approvals, to get their x-rays, but I don't bill insurance. And so that is the big deal for me about the difference between DPC and concierge care. One of the first concierge cares, or at least they call themselves concierge care, was here in Indiana. It was a big one in Indianapolis. And that's what was known through the area. So introducing DPC, I actually was the first physician DPC practice in Southern Indiana, which is a decent size area. There's an interstate that goes across the middle, which is Interstate 70. And basically anything south of 70 down to the state border is considered Southern Indiana. I'm actually at the very center of that southern part of Indiana, and there was no DPC practices. There's many more of us now, and I'm glad to be a part of it. We have our own DPC Facebook for Indiana, and so it's fun to be able to share things and to talk to people who are setting up. And knowing the laws and knowing how to do things in Indiana has been helpful. So that made it easier, and I love being able to share that knowledge with them.
That's fantastic. And I think so many things when you're sharing about your clinic, when you're sharing about your journey transitioning and the state of joy that you have now compared to what you described as burnout prior. And one of the things I think about when people do hear about DPC, a very common thing I hear from people who are learning about the movement is, but Dr. Lovins, aren't you always on call then? Like, do you ever get to sleep? So what would you say to those people who are concerned about burnout? Because DPC is another way to be a family doctor in this time in our country's history that is moldable, but that doesn't demand that it's going to come with burnout if you choose to not have it come with burnout.
Well, I think very much so. Setting boundaries with the patients is helpful. But honestly, because it's a relationship between me and the patient, they get to know me too. And so they're not calling me on the weekend. They're not calling me in the middle of the night. I had a patient who texted me at 5:05, and she realized it was 5:05, and she said, I don't expect you to answer me till tomorrow. I'm like, it's 5:05, I can answer you. So I really think there's a piece of it that because the patients have that relationship with me, they're less likely to interfere with those boundaries. When I was in that big practice, you didn't know who was going to call you. You didn't know who was going to be on call. And so I feel like those calls were significantly worse than anything I've ever had in this setting. I get maybe one or two texts on the weekend and answer it very quickly. I've told patients that if I'm available, I'm willing to see them if they need to be, but that's happened twice in 5 years. So, and they were babies. I mean, you can't not see a baby if they're sick. So yeah, I don't think that I've become overwhelmed by the patient interactions. And definitely burnout has not been an issue for me in this setting. I get that myth of people who are like, oh, how can you do that? How can you do that? Well, the difference is 500 patients versus 2,500 patients. And I know these 500 patients. And it's really interesting. My my phone tells me who it is that's calling, but most of the time I know their voice. And because we've just had that kind of relationship. I had a patient come in today. She goes, "You just have such a laid back kind of office. And I just really like it." And I'm like, well, that's me, so that's okay. I put out some pillows today that are Halloween pillows, and a little girl came in and she was just hugging them and having fun with it. It's just I feel like it's a home for them, and I want it to feel very comfortable. That's my goal in DPC, is to make people feel comfortable approaching medicine and getting the care they need. So
I love it. And I love the description of relationship-based medicine. This is what I think, especially family medicine doctors, primary care doctors really go into primary care for. And I love that you're delivering that. One thing that you mentioned is myths that you hear. And so I would love to hear, what other common myths do you hear about direct primary care? Because I have my list that I commonly hear, but I'd love to hear yours.
well, I think the biggest one that I hear is people are worried about the future of family medicine and the ability for us to see patients. But so much through what I've seen, and even in my own case, if I had not have found this, I probably wouldn't be in clinical medicine. And so I'm seeing 500 patients that if I had not done this, I would not be seeing them. So there's this myth that we're not going to have enough doctors, but if we're all getting burned out and we're all quitting the profession, we're not going to have enough doctors. I think that's probably the biggest one that I see from my advocacy with the AAFP, is people are worried about that. But when I reassure them that there are so many DPC docs who have been through that burnout and have made that conscious decision to do DPC versus quitting medicine, that's a significant number of physicians that are staying in medicine. And I think that's important. I think the other one is that whole myth about, well, it's only for rich people. I guarantee you, I live in a town that has a decent per capita, if you want, but the people that are coming to me are the people who can't afford insurance, or who work at a small factory who need help and care, and those people who don't have insurance. So it's not for the wealthy. It is definitely not for the wealthy. And I love that my patients come to me, even if they have insurance, and they're like, "Dr. Lovins, you can provide me with medicines cheaper than I'm going to get at the pharmacy. Do you mind filling my prescriptions?" I'm like, "No, that's what I'm here for, is to make things cheaper for you, or drawing blood on patients and making sure that we can save them money from that standpoint is very important to the whole philosophy of DPC." And I love the fact that I can do that for my patients.
Amen. And I cannot echo that enough, because literally, when you get the freedom to practice in the way that you need to for your patients, and every patient is going to be different, and you're able to be creative because that's what you get paid to do, you're literally working for them. It is a completely different game. And I will say, absolutely, those myths are very, very common. And I'm glad that you address them, because I do think that this is where more and more people are becoming aware that these are myths. More and more people are choosing DPC. Like we saw, I want to say 2 years ago. I want to say that the data that we got at the DPC National Summit that the AAFP co-sponsors was that in 1 year we had gone from like 4.5% to over 9% of AAFP members identifying as DPC. And I'm like, also, I wonder what's under the hood of the people who are planning on DPC who aren't identifying as DPC yet. And so I'm so excited to see you and see Dr. Tom White in Anaheim. So definitely, if you are a DPC fan, come find one of us and talk more about DPC. We love talking about it. When it comes to practice scope, this is another myth that I hear. And I mean, even today, you're like, skin cancer and warts and all the things. I would love to hear your perspective on, does DPC limit your scope of practice, or how does it work for you in terms of enabling you to be the doctor you need to be for your patients, which could require different skills on different days?
Many years ago, the AAFP brought forth this package of this basket of services that family medicine should be able to do. And when that came out, it was way in the 2000s, but when that came out, I never understood what that basket meant, because being employed, I was kind of dictated to what I could do, how long I had with patients. And so I made lots of referrals for patients, and because I couldn't do the things I wanted to do for them in the practice. So then they got referred out to the specialist, and the specialist took care of all of that. Well, I really feel like my DPC practice has allowed me to open back up my specialty and the services I can provide because I have the time to do it. And I can spend the time to do the workup. I don't have to send them right to the cardiologist for blood pressure that's not under control or troubles with their cholesterol. I can work with them because I have a much more close relationship with them. And it's not timed to a 5-minute visit or a 7-minute visit. And so my favorite is when I get a new patient, they are scheduled on my schedule for an hour and a half. They don't know that. They just know they have a new patient visit. And the clock for them is behind them in my office. And I love it when I get to about that 25, 30-minute point and I'm still asking questions and trying to get to know them. And they're looking around for a clock because they know they got to get done. They got to get done because I'm like, and about that time I say, it's okay. You've got more time. If you've got the time, I've got the time. And so it's just really such a different atmosphere, even interacting with the patients and giving them that time that they really do need. It has been a wonderful thing. I think the other piece for me has been the whole process of learning how to run a business.
Mm-hmm.
That was my favorite line that I've told people is, you went to medical school, you graduated, you finished residency, you can run the business. Don't worry about that. And if you don't want to run the business, because there are people that don't, find a practice that's looking for a partner, because there's lots of those settings where you can do it. But I love that part of it. It sounds really silly. I don't mind taking out the trash. I don't mind cleaning the toilets. I don't mind doing the inventory. That's a piece of it that I am so happy to be able to do. And it's been a really fun experience learning all of those things too, as part of this.
I love that. And that's perfectly dovetailing into what I wanted to ask, because as you are a micropractice clinic, you are you are the physician and the hat wearer, as you just described, of many different hats. Tell us about how you administratively manage your day, because we heard about how, like, the patients that you saw today, but how do you mix in the administrative back office, so to speak, part of your clinic so that you're able to not use a waiting room for waiting? That's a very classic thing in DPC that we joke about.
Yeah, yeah, absolutely. So I figured out very early that if I set aside time in the schedule so that I have it to do that paperwork or to do that inventory, it gets done. And so I literally, my schedule is Monday through Friday. It is scheduled 9 to 4:30. I see patients before that. I see patients after that, depending on what they need. But I set out a 2-hour time block for meetings, for time to do the administrative things. And it just really made it easier for me because I know that every Thursday I'm going to be able to set up a meeting if I need to do that with somebody, or talk to a drug rep if I need to, or just do the inventory. Care wants an inventory every week. And so it's very easy to do that with that time frame. So that's how I did it. I think in the first couple of months, because my patients were very far between, I was able to do it between time. But as I got a little bit busier, some days are a little bit more full. And so I just wanted to make sure I had a set time to do it. And that's how I chose to do it.
And I think it's so important here to mention that this addresses another myth in DPC that, it's not for everybody, because you're going to get lonely. If you open and you're by yourself, like, where's the bunch of residents who share the same computer room or whatever? So tell us more about how you remain part of a community of active physician entrepreneurs.
Yeah, I appreciate all of the different social media outlets to be able to interact, attending the summit, getting to know people from the region, which is the Midwest region, and just being able to literally reach out to anyone. I've never had a single other DPC doc say, I don't have time for you right now. And so that's been very, very helpful. I think, again, we have a nice social group on social media for Indiana. And so being able to share that information, where'd you find this? Where'd you find that? How are you doing this? And it's been a nice piece to be able to use those resources for me to set up the practice. Yeah.
I love that. And It's ironic that you and I are recording this on Physician Suicide Awareness Day. I actually dropped an article on SoMeDocs this morning about going out to our colleagues in direct primary care and the direct care space. But I'm wondering if you can talk to us in the lens of the people who might be considering taking their own lives, leaving medicine. How do you think DPC can contribute to a person's psyche when it comes to the mental health that we too often put aside when we're especially in primary care?
Yeah. I think it's very important to know that in one of my situations in my previous life, I had panic attacks going into work. I had anxiety. I had that whole scenario of all of the mental health issues that were just overwhelming me. And so I see that this has calmed all those things down and has just been such an asset to me personally. But I also think there's another piece about DPC that we sometimes forget. Because I'm not associated with a hospital system, I have lots of patients who come to see me because I'm not associated with a hospital system. And so that's even better from a physician standpoint to be able to say, hey, listen, no one's going to see your chart. It's just me. And there's, especially for the physicians in town. And so that piece I think is important. We had in our littler community, it's a decent sized community, but we've had 3 or 4 physician suicides in the 20 some plus years I've been here in Columbus. And so it's a very personal thing for me because I'm very open about my mental health issues. I've had depression postpartum started. My oldest is 30, so that tells you how long I've had a diagnosis. But when I got into that career, that job that was just overwhelming me, I knew I had to change. I tried a couple other things in the meantime, but this is what's worked the best for me. One of the things that I posted about today about physician suicide was the Lorna Breen Foundation. She is an emergency room physician who got COVID and then had mental health issues from her COVID. She was having mental health slowing, she got depressed, and she committed suicide during COVID. And her family put together this wonderful foundation that is supporting physicians and their well-being, all healthcare workers and their well-being. It started with physicians. And they actually are the underlying force behind many states changing their licensing requirements to ask you about your mental health. And so I find that a very worthwhile foundation to continue to follow. I think suicide is important, and I think I think physicians need to know that it's okay to ask for help and that it's not a fault of yours. It's a fault of the system that it can't take care of us to keep us healthy. But yeah, there's things we can do. We can be better weight, do more exercise, eat healthy, sleep well. But I think the system sets us up for failure and not our failure. And so I think it's important that we talk openly about suicide and suicide prevention.
And I will say, if you haven't heard from someone in a while and they're very dear to you, check on them. I definitely will say that it is so common in primary care, especially because it's our faces on the billboards. It's our faces on the corporate whatever advertisement marketing campaign. And it's our souls that choose to go into family medicine, primary care of any sort, and specialty care. It does feel very personal because most of us are going into this because we want to help others. And then when we conveniently are groomed to not remember to take care of ourselves, I will say that if you know of a person who is in that realm, check on them because you can call that out because especially from colleague to colleague, we've been in the trenches. We've all been in different residencies, different night calls. The pagers have been
Absolutely.
going off and we know what it's like. And so who best to check on someone but your colleague who has been there and done that. So yeah, so important. Thank you so much for mentioning that resource and I'll make sure it's in the show notes. So my next question here is how do we change the landscape of access to amazing healthcare like you're delivering at your DPC? Because I think about as I sit on the strategic committee and the education committee at the California Academy of Family Practice chapter, that I feel sometimes like I'm banging my head against a wall when I talk about anything other than a 99213. Let's put that 25 modifier on, guys. Like we can't forget that 80 to 90% of the family medicine residents in California go into employed medicine. But it's also more and more that the people in first year and second year of residency are planning on going into direct primary care. So I'm wondering if you could tell us your thoughts and what you're seeing from where you are at the AAFP as to how we can change the landscape to get people to know what family medicine can be and to love family medicine and to choose it for their career.
I think part of our issue as physicians in training, as a resident, so many of our residencies are tied to hospital systems. And so those hospital systems want to keep the primary care doctors. They're a great referral service, right? They know what kind of money that primary care brings into their facilities. And so they don't offer the opportunity to learn about other options. So I think as DPC doctors, we need to get out there to the residencies and really let them see and know about DPC and what independent practice looks like, because that's another piece of it. I mean, even if you don't want to do this model, if you want to be out and be in charge, then independent practice is a way to do that too. So I do think that there's been a lot more social media. I think there's been a lot more interactions with residencies. In Indiana, there's several on our state board who are DPC doctors. And so we've been going to the residencies and kind of teaching. I have a message from a residency wants me to come and talk sometime soon, they said. And I'm like, I have a little bit to do in October, but I think it's very important that we show them that there are other options, that being employed is not the only option. It was very convenient, even when I was in training, because that was the point in time where, knowing how to code, knowing how to get money, knowing how to do the billing and collections was very much not taught to the physician. And so they couldn't be the director of their practice if they didn't know those things. And so now that it's much more open and there's so much more ability to learn that information, we really have to be able to support them in that. And I think that's a big part of how we get those residents to continue to want to do DPC, or how we get those physicians to realize we're not the enemy in DPC. We're just taking care of patients a different way. It's no different than somebody who's doing sports medicine or somebody who's doing addiction medicine. This is just a different style of family medicine, but it's still medicine and it's still taking care of the patient, and in a way that I feel much more comfortable taking care of a patient.
Amen. And I love that. And I do think that, especially for the listeners out there, if you're like, oh my goodness, I would love to have a DPC doctor come talk to my community, whether you're a resident, a medical student, and attending, whatever the heck it is, I definitely echo Dr. Lovins in saying just literally Google your town DPC, whatever you got, and you'll find one of us out there. DPC's in all 50 states. California, we have our calidpc.com. So if you're in California, reach out to us. The Indiana crew has already created their Facebook. It's like there's community where you don't know that it's there. So I definitely will say it's as literally as easy as dialing one of our numbers. I joked I called Dr. Lauren Hetty one day before her recording on the podcast because I knew that she was going to answer the voice message and not some assistant, because she's like you, a micropractice. So I love that. So let me ask you here, in terms of you not only being a DPC doctor, I also want to talk about how like we were talking about, seeing and learning about DPC is so important because it can change your trajectory as to what you think family medicine can be. And so I'm wondering if you can talk to us, because I have my biases about this very clearly, but it's like, what is the importance of somebody who is living the life of a physician, who is seeing patients, running their practice as a physician entrepreneur? Why is it so important that somebody like you be in the presidency of the American Academy of Family Practice?
Well, I think twofold. There are three candidates who are running, and I think it's very important that we keep on that board physicians who are doing clinical care and taking care of patients and being in an independent setting. DPC is a form of independent family medicine. And I think it's very important that we continue to keep that. Yes, I know the statistics. I've seen them. It's 11% now. But I think it's very important that that board, that executive team, those officers include someone who is a minority in the style of medicine that they do. And so that's what I want to present as a president-elect, is the ability to speak for those that are in that minority, and to really amplify the signal that it's okay to do this. You can survive. You are not going to be overburdened. You are not going to be overwhelmed. And so moving into that position, I think is very important for allowing other family docs to see that private practice, independent practice, clinical medicine is still important. And this is one style that works very well. It may not work well for 100% of them. I don't expect that, but I would hope that we would see that 11% keeps going up, especially as we're seeing the residents being much more involved and much more interested. I had a great time at the DPC Summit. It was the biggest one I've been to, and I've been to 4. And I was ecstatic about just the number of people and the way they had to change the lecture hall because there wasn't enough seats. And I'm excited about that. How do I want to describe it? I would describe it about the enthusiasm of our membership and doing DPC.
There's so many ways that we describe it, like drinking the DPC Kool-Aid, taking the red pill, all of the things. It absolutely represents the enthusiasm that we have as physician entrepreneurs, because we are doing so much change in our communities that we've always probably wanted to be a part of, at least. And we couldn't necessarily do that when we were back-to-back Medicare physicals, asking people if they wear their seatbelts. Great.
Right, exactly.
So
Or asking them a hearing screen and then not being able to afford hearing aids. So why do we screen for that if Medicare doesn't pay for the hearing aids? So yeah.
makes complete sense to me, for sure. So I would love here if you can give us some examples of like your most DPC days, because already you've described your day to day, but I'm wondering if you can leave us with some other examples of only in DPC could I have achieved this.
Well, one of my days involved, actually, I was heading out of my practice for a meeting, and a mom called and she said, "My kid, he fell, his hand hurts. I don't know what's going on. He won't move it." And I actually stopped by their house on my way to my meeting and spent time with mom, walked him through it, gave the little child, it was just a contusion. It wasn't anything big, but it was the event that I could go and tell the mom, this is what you need to do and how to do it and take care of him at the same time that I'm heading to do advocacy at the state. And so that I think was the epitome of the two sides of my practice. My busiest day up until about a year ago was I want to say it was 9 patients. And people are like, "Oh, DPC, 9 patients. What are you talking about?" And I go, "Well, 7 of them were from one family. So it wasn't so bad." But that I think is a little overwhelming when you're trying to get them all into one space. But yeah, there's just so much that I can do in here. I have an EKG machine, I draw blood, I have medicines, I do dermatologic procedures. Ironically, I'm next door to a dermatologist. So, and it's just like today, the patient that I treated today for the skin cancer, she'd actually gone to see the esthetician at the dermatologist office, and she missed some lesions. She's like, can you just take care of them while I'm here? I'm like, sure, why not? She'd come in to talk to me about weight loss, and we got into freezing some scaly lesions on her hands. So yeah, it's been an interesting experience. Love my kids. I love my kids. But sometimes even the elderly patients that I'm bringing in the back door, because that's where the handicap ramp is, and my exam room is right inside that door. I love that too. I have a patient who brings her dog. He's been here probably more than my dog has been here, but I do sometimes bring my dog to the practice. And so, yeah, he comes right in, comes right down the hall, comes right into my office and lays down at my feet. So that I think is the epitome of a DPC practice, is the ability to say, "Hey, you know what? Bring your dog in. It's okay." And just to be that it's her companion and she needs it. And so to me, it's a wonderful way that I can make my practice accessible to her.
I love it. So, my last question is regarding the new legislation that has become law in terms of the Primary Care Enhancement Act, passed as HR or as part of HR 1 in the big beautiful bill, where DPC memberships can now be paid for by people who are funding their HSAs. And so I will say, especially if you're already on the DPC train, if you want to be, but you're not there yet, if you have patients who are looking for ways to solve their healthcare access problems, issues, fill in the blank after the beginning of the year. I'm wondering if you can speak to us to the people who are wanting to talk to people in their community about how to maximize HSA benefits and getting a DPC membership at the same time.
Well, I think I have a small company that I work with, and they offer just basic insurance. Really, it's catastrophic insurance, but not by that label. And so they are able to put money into their HSA. But up until now, it was iffy on, it depended on across the city. It depends on who's administering the HSA because some of the HSAs they went through just fine. But now to have the actual law that says that you can use your HSA to see a DPC doctor, I have already seen patients that are excited about this and, hey, I'm going to increase the amount of money I'm putting in my HSA because I know I can use it for this. And so to me, that's a huge asset. I know the Academy has been working along with the coalition to try and get this. And yeah, they had to put a price limit on it. I understand that piece, but I think a lot of patients, especially those in the marketplace, who are going to be probably dropped off the marketplace because they can't afford it. This is a way for them to be able to get catastrophic insurance and still have a DPC doc because now they can still put money in their HSA. And pre-tax dollars for anybody are pre-tax dollars, right? And so the ability to use that for their healthcare, I think, is very important. And then the fact that I can do 80 to 85, 90% of their care right here, they know exactly what their cost is going to be. And that is, I think, also very helpful for them.
Yeah.
So yeah, I think it was a great thing. I'm glad it went through. I think, and it's indexed. I think that's the other piece that
It
people
is.
don't talk
For
about.
inflation,
Like
yes.
$150 for a person and $300 for a family, but they actually wrote into the law that it's indexed for inflation. So
Correct.
we're going to see that number go up every year too.
Yeah.
Which I think is important.
And I will say, just calling out your own membership fees on your website, 0 to 5 years old is $30 per month with a paying adult, and it just is increasing by age group. So $50 per month for ages 6 to 17, $60 per month to 8 for ages 18 to 40, $75 per month ages 41 to 64, and $100 per month ages 65 plus. So I want to make sure that we're also mentioning those prices because for those people who are really learning about DPC and trying to make that distinction between concierge, $40,000 a year plus billing insurance, like they do in the Bay Area in California, that is not the thing that is happening at your DPC. So when you index for inflation, it definitely your lens is different than a concierge doctor.
Yeah.
So
And then I have a maximum fee for families too, and it works out to right about, depending on their age, but about 4 people is where that comes in, and it's still below that $300 for the family for HSA. So
amazing. So where can people find you to connect with you after this interview, but also in Anaheim when we get to see each other in person?
yeah. Well, I will be around everywhere, but you can connect with me. I have a website. It's lovinmyhealthdpc.com. There's an email on my website that you can email me. That'll go straight to the email that I'm the only one answering. So obviously you're going to get me. I have an office number. My office number is 812-900-2883. And that humorously rings to my cell phone that you sent messages to me. And so I have 2 lines on my phone. So I get text and phone calls on the same phone. And anyway, when we get to Anaheim, if you want to meet up with me, text me and I'll try to figure out where we can meet. Another place that you can get to know me, to meet me, is there's a hospitality room for all the candidates for AAFP officers. And I will be in there and I will be proud as a DPC doc because I do want to talk to people, family docs, about being the president-elect. And I do want to talk to people about DPC. So I think it's very important that we continue to nurture those that are interested.
Amen. And I will say, if you are there and you're a DPC doctor, I've already had a few people reach out and say they're going to be there. We are going to be doing a My DPC Story live event with Dr. Tom White and doing a live interview, but also I'll be going around with my roving mics and you can't miss me. So I'm so excited to see you. I'm so excited that you are running and you definitely have my vote. I am not a Congress of delegate, but I am still voting for you with all that I can muster. So thank you so much, Dr. Lovins, for sharing your DPC story today. Thank you for listening to another episode of My DPC Story. If you enjoyed it, please leave a 5-star review on your favorite podcast platform. It helps others find the show. Have a question about direct primary care? Leave me a voicemail. You might hear it answered in a future episode. Follow us on socials at the handle @MyDPCStory and join DPC Didactics, our monthly deep dive into your questions and challenges. Links are at mydpcstory.com. For exclusive content you won't hear anywhere else, join our Patreon. Find the link in the show notes or search for My DPC Story on patreon.com. For DPC News on the daily, check out dpcnews.com. Until next week, this is Maryal Concepcion.